Our next speaker, by her own account, has spent 20 years obsessing over how to make healthcare more just and more rational. Today, she'll challenge us on how to reach that vision using tools that we already have. Please welcome Rebecca Onie.
So today I want to talk about what does and does not count as healthcare in this country. For me, the story begins in 1995 with a freshman year internship in the housing unit at Greater Boston Legal Services. I was paired with a righteous, deeply inspired attorney named Jeff Purcell, who thrust me onto the front lines from the very first day. And over the course of 9 months, I had dozens of conversations with low-income families who would come in presenting with housing issues, but there was always an underlying health issue. My first client was about to be evicted because he hadn't paid his rent, but he was paying for his HIV medication and couldn't afford both. Or we had a mother who came in, her daughter has asthma and wakes up every morning in an apartment filled with cockroaches. And I grew frustrated, feeling that we were intervening so far downstream in the lives of these families. And in June 1995, read an article about Dr. Barry Zuckerman, then chair of pediatrics of Boston Medical Center. With Barry's blessing, I spent 6 months talking to doctors and nurses and heard the same story again and again. They said every day we have patients that come into the clinic and the patient has an asthma exacerbation, we prescribe a controller medication, but we know that the real issue is that she's living with 12 other people in a mold-infested apartment, and we don't ask about those issues because there's nothing we can do. We have 13 minutes with each patient, patients are piling up in the clinic waiting room, and I have nowhere to turn for help. Now, it seems that it shouldn't be so complicated to design a doctor's visit around what patients actually need to be healthy. But I've had hundreds of conversations with physicians across the country who say that when it comes to their patients' basic resource needs, they practice a don't ask, don't tell policy. HealthLeads was born of those conversations and the conviction that there had to be a better way to leverage the assets of our healthcare system to do right by patients and by the providers who care for them. So fast forward 20 years, what's changed? It's now well acknowledged that just 10% of health outcomes are attributable to medical care, and the remaining 70% are attributable to social and environmental factors and the behaviors so influenced by them. We've also proved that it's actually possible to do something about these social needs with real results. With our healthcare institution partners, HealthLeads has created 30 of these proof points, clinics that have swept aside don't ask, don't tell, and instead armed their physicians and other healthcare providers with prescriptions for food, heat, and other basic resources that they need to be healthy. We equip healthcare institutions with tools, screenings, analytics, workflows, a customizable technology platform, to mobilize community health workers, care managers, and even college student advocates to work side by side with patients to access the existing landscape of community resources. And these connections work. A recent study at Mass General Hospital found that addressing patients' social needs, in that case through HealthLeads, yields clinically significant improvements in blood pressure and cholesterol levels, the former at a level that would satisfy the FDA threshold for a new drug. We found that when you address patients' social needs, 69% of those patients are more likely to recommend their clinic, which makes perfect sense, right? That folks are happier when they encounter a healthcare system rather than a sick care system. But here is the part that troubles me. Notwithstanding all of that momentum, there is not yet still a single healthcare institution in this country that has made screening patients for and navigating them to community resources a standard of care. Not a single one. And I think we have to look that disconnect in the eye. Why is it that we can be accountable for every detail of our patients' clinical comorbidities, but when it comes to their social comorbidities, we're willing to settle with, they're on Medicaid, or they're poor. What does that even mean? How is it that the SVP of quality at a major integrated delivery system that collects thousands of pieces of data about its patients still says our patients' psychosocial needs are a black box to us? How is it that the challenge of keeping the lights on at our institutions has somehow become more all-consuming than the challenge of our patients keeping their lights or their heat or their electricity on at home? What we need, what we desperately need, what our patients need and what our sector needs is a paradigm shift. So in 1962, Thomas Kuhn, the physicist and philosopher of science, created this phrase, paradigm shift, which he defined as a revolutionary upheaval in the basic assumptions of the ruling theory. Kuhn explained that in every paradigm over time, enough anomalies and contradictions accumulate that the discipline goes into a crisis period, characterized, he said, by a willingness to try anything, the explicit expression of discontent, and debate over fundamentals. So I don't know about you, but that sounds exactly like the conversations that I am having with healthcare executives all across the country these days. Nobody exactly loves the current paradigm. And yet it's not clear what should replace it, and this is where you come in. Because the most compelling part of a paradigm shift is that it only requires the courage to see the world differently and to act accordingly. So to make this point, Kuhn showed this image. How many of you see a duck? And how many of you see a rabbit? Okay, I'm just going to say I'm a rabbit gal myself. But it all depends, of course, on how you look at it, right? As Kuhn says, a paradigm shift is about handling the same bundle of data as before, but looking at them in new relation with one another because of a different framework. The question is, what will it take to shift the paradigm, to address social needs as a standard of care, and bring us closer to a more just and more rational healthcare system? I think it would mean embracing three imperatives. Imperative number one is to change the definitions. Our definition of what counts as healthcare in this country did not come down from the Mount with Moses. It is of our own construction, and we can choose to redefine it. So consider Carlos, who presents with multiple sclerosis, unmanaged diabetes, having missed multiple specialty visits and had many ER visits and hospitalizations. We have a lot of words for Carlos in our current lexicon, right? He's high maintenance, he's a frequent flyer, he's non-compliant, all of which assume his willful disregard for his doctor's care. But with health leads by his side, Carlos accesses a bilingual transportation company, secures vouchers for his medication, and navigates the mysteries of scheduling his follow-up appointments. And he makes his next 7 doctor's appointments. Now his doctor says, Carlos trusts us. This work does not have to be super complicated, but if it's done systematically, it is paradigm shifting. And in this new model of quality care, Carlos is no longer a problem patient, a worst case, a special case. He's just a guy with a few more comorbidities. In traditional healthcare, we define comorbidity as the simultaneous presence of 2 chronic diseases or conditions in a patient. But why? Why don't we consider a comorbidity the simultaneous presence of any 2 conditions that compromise the health of a patient? Why do we count diabetes and obesity, but not that a patient's running out of food at the end of the month? Can you imagine if NASA said that they were going to calculate the force required to get a rocket into space but not bring it back down to Earth? If they said, we're in the space exploration business, not the air travel business, so that last 50,000 feet that the astronauts travel between Earth's surface and Earth's atmosphere and the surface, that's not our problem. I mean, that would just be preposterous, right? But that's how we've structured healthcare today, where that last 50,000 feet, the actual difference between illness and health, is somehow somebody else's business. So if imperative number 1 is around language, number 2 is around action. Imperative number 2, change the work, address social needs as a standard of care. So last fall, I sat with Ray Baxter, an SVP at Kaiser Permanente, one of HealthLead's partner institutions, and Ray framed the dilemma this way. He said, at the one end of the spectrum, we could just pretend that these issues don't even exist in our patients' lives. Or on the other end of the spectrum, we could actually go build the affordable housing. And he said, we know that neither of those is exactly the right answer, but what is the role and responsibility of healthcare institutions with respect to patient social needs? Ray's question sweeps away this false choice between doing everything and doing nothing. And that's the whole nature of the paradigm shift. It's not about doing everything differently or nothing differently. It's about taking our existing assets and deploying them differently. The facts don't change, but how we see them and what we do with them does. So first, we have to break the cycle of don't ask, don't tell by expecting our providers will have the same rigorous understanding of patients' social needs that they do of their clinical needs. We would never accept just a diagnosis of cancer. We want our physicians to tell us what type, what grade, what stage. Same with community resources. If those fancy new ICD-10 codes can require us to report when a patient was sucked into a jet engine, code V97.33, or better yet, pecked by a turkey, code W58.13, which I'm assuming is like a seasonal code, then surely we can screen patients for whether or not they're running out of food or whether their heat got turned off in February. The second is we have to act on what we learn. We have to navigate patients to community resources the same way we would to a specialist or a home health agency. The ultimate bad handoff, giving a patient an outdated list of food pantries and expecting her to navigate the language, transportation, and bureaucratic obstacles to her actually getting the food to feed her family that night. Number 3 is we have to build strong referral relationships with these community organizations. You wouldn't want to send a patient to a cardiologist you don't know. Same with community resources. And step 4 is to collect data about this work. It is still science. It is actually more precise science, holding ourselves accountable for the outcomes of health, not just the inputs of medicine. And data will tell you surprising things. So during one HealthLead's implementation, we in the clinic leadership assumed that the screen positive rate for unmet resource needs among the patients would mirror the clinic's Medicaid population, about 20%. So we were shocked when we found that 58% of the patients reported a significant unmet resource need. 58%. If you knew that 58% of your patients did not have food or housing, you'd probably want to include that information in your performance dashboards or your strategic planning, the same way you would clinical and financial information. So how do we go from healthcare to health tomorrow? And I think this is where Kuhn's wildlife becomes really helpful. If we look at all the assets of our healthcare system, our technology, our workforce, our infrastructure, and view it through the lens of health rather than disease, we unlock incredible potential, right? The rabbit becomes a duck. So how complicated would it be to write prescriptions, not just for what a patient needs to get healthy, but what they need to be healthy, like food and housing? To maintain a registry of patients who are food insecure, the same way we maintain a registry of patients with heart failure. Or to deploy our discharge planners, not just to schedule a follow-up visit with the PCP, but also with a job training program. Or use our financial counselors not just to enroll patients in Medicaid, but also in SNAP benefits. So many of the tools and resources to deliver health already exist, and you can enact the paradigm shift by seeing and using them differently and more fully. The third and last imperative is for us to be the leaders our patients are hoping we will be. So one of my heroes is Tom Lee, a physician at the Brigham and Women's Hospital and the CMO of Press Ganey. And I think Tom has scrutinized every square inch of the healthcare system, from quality to value, experience, and efficiency. But I still think his most profound insight is his simplest. Tom said to me, you know what all this healthcare strategy stuff is really about at the end of the day? It's about recognizing that every patient visit is a high-stakes interaction. It's a big deal for the patient, and it's a big deal for you. And all you have to do is be the physician your patients are hoping you will be. So what would it mean for us to be the healthcare leaders our patients are hoping we will be? I think it would mean looking the full picture of health, refusing to avert our eyes any longer from 70% of what impacts patient health. It would mean discarding don't ask, don't tell, and diagnosing Carlos with MS, diabetes, and insufficient transportation. To get there will require taking some risks and performing some courageous acts. But as Avedis Donabedian, who founded this whole study of quality in healthcare, said, it is exhilarating, even ennobling, to believe that the obstacles to good care can be circumvented or removed by ardently wishing it so. If you wish it so, if you act accordingly, you will join some pretty spectacular inside agitators who have already rejected the status quo and are working to architect the future. Leaders like Nirav Shah, the COO of Kaiser Permanente Southern California region, who says the surest path to the triple aim is through addressing our patients' basic resource needs. This is our work. It's not just our mission, it's a strategic business imperative. Leaders like Peggy Troy, the CEO of Children's Hospital Wisconsin, who used every patient visit in every clinical and non-clinical setting to screen for and provide her patients with immunizations, and has committed to do the same with respect to screening for and addressing their social needs. How do you convince a skeptical CFO of the importance of this work? Peggy's answer is simple. If you have to convince him, you probably need a new CFO. And leaders like Jack Geiger, who probably started the whole thing in the first place. In 1965, Dr. Geiger founded one of the first 2 community health centers in a desperately poor area of Mississippi. So many of his patients presented with malnutrition that he began writing prescriptions for food. And patients would take those prescriptions to the local supermarket, which would fill them and then charge the pharmacy budget of the clinic. And when the Office of Economic Opportunity in Washington, D.C., which was funding Geiger's clinic, found out, they were livid. And they sent down a bureaucrat to tell him that they had intended their dollars to be used for medical care. To which Geiger famously replied, the last time I checked my textbooks, the specific therapy for malnutrition was food. But here's the thing. In 1965, Dr. Geiger could not instigate a full-on paradigm shift because he was too busy, in his words, fending off the wolves, the rabidly racist physicians, state medical societies, and politicians who sought to end his work for good. He didn't have our privilege or our responsibility of leading in a time of unprecedented fluidity in the healthcare sector, in which the changes of health reform allow us to shed the old paradigm by changing the definitions, including what counts as healthcare, by changing the work, assuming responsibility for addressing patients' social needs, and by being the leaders our patients hope we will be, by refusing to do something as important as health with one arm behind our back. And the crazy part of it is, to get there, we don't need a single new innovation, invention, or insight. We just need to see things differently and act accordingly. It's not a rabbit, it's a duck, and that will make all the difference. Thank you.